Welcome everyone to our Legacy Society webinar titled Matters of the Heart. My name is Elizabeth Tadaldi and I'm the Associate Director for Planned Giving here at Mount Sinai. And I'm so happy to be here with you today. For those of you who have attended our webinars and events in the past, we are so happy to be here with you virtually. And for those of you who are new to our Legacy Society webinar this year, we're happy to have you and welcome. A quick note, if you have any questions during the panel that you would like answered, please feel free to use the bottom Q&A function on your screen. During the Q&A portion, we will try to answer as many questions as we can. And you may have noticed when you receive this invitation that it says Legacy Society, and this is one that we would traditionally hold in person for our Legacy Society members. And as we are virtual this year, like many of our events, we are happy to extend it to those not in our Legacy Society and for people who might be interested in learning more about what is Planned Giving at Mount Sinai. A little bit about our Legacy Society is that it is a member of, it's an esteemed group of people across the health system who have established their legacy with Mount Sinai by making a planned gift. At Mount Sinai, legacy gifts span from the traditional bequest gift to also options for life income gifts, such as CGAs, also known as charitable gift annuities. And these gifts, whether bequest or life income gifts, are really important to the institution because they place us on the forefront of healthcare excellence in perpetuity. And if anyone here listening today has any questions about our Legacy Society or Planned Giving, or if you do have Mount Sinai in your estate plans and you haven't yet let us know, please feel free to contact us. My contact information will be sent out at the end of the webinar, and feel free to contact me. I am here and I would love to chat more with you. There are numerous benefits to being part of our Legacy Society, and one of them is what we are witnessing today, and that is invites to exclusive webinars and when we can meet safely in-person events discussing cutting-edge topics. And every year we try to pick a topic that we hope arms you with knowledge about how to best protect your health, as well as showcase the amazing things happening at Mount Sinai. And I know that this year's content discussing matters of the heart will be not only extraordinarily informative, but also extremely interesting. And I am so pleased to have Dr. Swirsky, Lala, and Reddy here with us today to serve on our panel. And it is my absolute pleasure to introduce Dr. Roseanne Leipzig. Dr. Leipzig is the Gerald and May Ellen Ritter Professor. She is the Vice Chair for Education at the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine. She is internationally recognized as a leader in geriatrics and evidence-based medicine. Her research and publications highlight models for teaching geriatrics, chronic care, and evidence-based medicine. She has received numerous awards from prestigious organizations, including the American College of Physicians and American Geriatric Society, and services and advocacy for GLBT elders, SAGE. And without further ado, it is my pleasure to turn it over to Dr. Leipzig.
Thank you, Elizabeth. And it's a pleasure to be here. I also am missing our in-person times at the Carlisle, but hopefully they will come again and come again soon. I'm really pleased to be able to moderate this panel for you. The three people who will be speaking to you will be speaking about things that are very near and dear to your hearts, literally, and to mine. As a geriatrician, to hear cardiologists talk about function, talk about sleep, talk about biologic versus chronologic aging is music to my ears. And to hear people talk about AFib and ablation is also music to my ears, having had an ablation earlier this year. So living proof that these things work. It's really my pleasure to introduce each of the panelists. And I'll start with Dr. Swirsky, who will be speaking first. Dr. Swirsky is the director of the Cardiovascular Research Institute. Dr. Swirsky.
Thank you very much. It is a real pleasure to talk to you today about some of the work that is ongoing at the Cardiovascular Research Institute here at Sinai. work that in many ways really seeks to understand how our lifestyles keep us healthy, and conversely, how our lifestyles can also lead to disease. And so what I want to do over the next few minutes is just to sketch for you how we think about lifestyle and how we think about cardiovascular health during our day-to-day as we do some of the research to better understand cardiovascular health. And so one very simple, but I think very powerful concept that I would like to convey to you is that in order to understand our cardiovascular health, truly understand it, we really must begin to understand how our various systems interact together. So we can think of ourselves as existing in the environment and in the world, interacting with our world, but we also inhabit one body that is not just a mesh of tissue, amorphous tissue under our skin, but that is held by a skeleton, and that is really a constellation of multiple systems. So we can think of our heart and our blood that is oxygenating and delivering oxygen and nutrients throughout. We can think of our defense system. We can think of our brain and everything that is associated with our brain. And then, of course, we can think of our gut, and there are specific names that are associated with these. And so as we think about cardiovascular health and what does that mean, one may be tempted just to look at this in isolation. We're just looking at the circulatory system. But if you look closely, so certainly if we look at the circulatory system when we're looking at the heart, we know that things can go wrong. We know that if we have a blockage in a vessel that supplies blood to the heart, that is a consequence of a disease called atherosclerosis, that this may in fact lead to myocardial infarction. But if we take a microscope and look deeply into what is happening in that tissue and compare the tissue of an infarct to a healthy heart, we see a very different picture. So for example, we see that here in this heart that has been infarcted, there is a huge influx of cells. And that raises the question, where are these cells coming from? What are they doing there? Are they important, and should we understand them? And so, of course, that raises the question, are other systems interacting, talking to each other, and influencing the cardiovascular system? One particular system is the immune system, that the defensive system that plays a particularly important role in this. Now, the question is why? Well, we know that in the bone, there is the bone marrow, and the bone marrow is really the birthplace of immune cells. Virtually all of your blood that is red is generated in the bone marrow. Platelets, which really cause clots, they are born in the bone marrow, as are many white blood cells or immune cells that we find in abundance after myocardial infarction. So this is just one example of why we should be studying inter-organ communication. We should better understand not just what happens in the heart or the vessel, but we need to understand what happens throughout the body and how these systems communicate that. Now, why should we be understanding this? This comes down to this idea of chronological versus biological age. And the concept is quite simple. Chronological age is simply the passage of time. We celebrate chronological age every time we celebrate our birthday, and there's not much we can do about that. Biological age is the age of our systems. It's the age of our biology. It's the age of our tissues. And we can modulate that. We can measure the age of those tissues by various ways. And we can potentially modulate the biological age, either having the biological age being older than our chronological age or younger. And the goal here is to really live meaningful lives, and despite our ongoing chronological age, to remain biologically young. And so, of course, that raises the question, what influences biological age? And so just if we were to look at ourselves as a collection of tissues, of cells, of genes that keeps us healthy or that in some cases makes us sick, it is the lifestyle that we engage in. It is the environments we inhabit, voluntarily or involuntary, that play a major role in modulating biological age. And so we know that certain lifestyles are good for us. We know that certain lifestyles are bad for us. Certain lifestyles are complicated. Stress is one that is very complicated. Diet, of course, is very complicated, and there's still a lot that we don't know. But one of the questions that we really want to get at the Institute and here at Sinai is not to really determine whether a lifestyle is good or bad for you, but to learn from nature. The idea being is that in many ways, our bodies, our systems, nature has figured it out. Nature very quickly adapts to perturbations in our lifestyle, in our environments. And that changes the biology. And if we can understand how different lifestyles, stress, sleep, diet, exercise, modulate some of the ways that organ systems communicate to each other, modulate the cells that are important in cardiovascular health, change the various processes, then we can understand cardiovascular health in this breakdown. And in addition, just to knowing it, just having a much better appreciation, we can then lead better, healthier lives and become biologically young or continue to be biologically young despite our chronological age. Thank you.
Thank you very much, Dr. Swirsky. That was really very clear and concise, and I think made several points that people haven't thought about before. So thanks a lot. Our next speaker is Dr. Vivek Reddy, and Dr. Reddy is the director of the Cardiac Arrhythmia Services here at Mount Sinai. Dr. Reddy.
Okay, thank you very much. Hopefully I have the right screen that I'm sharing here. Okay, so what I wanted to talk about was atrial fibrillation. Actually, can you guys hear me?
Yes.
Okay, great. So what I want to talk about is atrial fibrillation. So atrial fibrillation is the most common sustained heart rhythm problem that we encounter. And it's a condition that increases in frequency as we get older. In fact, the estimation is that 1 in 3 adults will experience atrial fibrillation sometime over the course of their lifetime. So it's a pretty high percentage of us that will develop atrial fibrillation. And it certainly is true that as one has more risk factors, such as high blood pressure or diabetes or sleep apnea, that the incidence and the development of atrial fibrillation increases over the course of our lifetime. So certainly decreasing some of these risk factors is likely to help in terms of the development of atrial fibrillation. But having said that, it's still likely, again, that a significant proportion of us will develop atrial fibrillation. So what do we do about it? Well, one of the big changes that has occurred over the past year and a half is our understanding of what exactly happens if we try to control atrial fibrillation. In the past, the only time we would really try to intervene on atrial fibrillation is in individuals who had symptoms from the atrial fibrillation, such as palpitations or shortness of breath or fatigue. Now, more recently, there was a trial. I'm just going to show you one data slide. I promise not to show too many data slides, but this is an important one, which is an important trial called EAST. And what EAST did was to look at patients who had atrial fibrillation, and in a large group of patients, and a couple thousand patients, and in half the group, they were in this usual care group, meaning just the usual, make sure that the heart rate is not too fast and put on blood thinners, versus the rhythm control group, which is to try to get and keep people in regular rhythm, so to convert the atrial fibrillation to regular rhythm. And what was important was the trial was actually stopped early because there was a 21% better outcome if you achieve regular rhythm. And this is something that we expect to have to continue over the course of one's life. And these curves will continue to diverge. There was improvements in death, so longevity is improved, stroke is decreased, and hospitalization is decreased. So, and one of the most important aspects of this is that it didn't matter if patients had symptoms. So even if one had asymptomatic atrial fibrillation, the benefit was still there. So now, instead of just looking at symptoms, we basically look to see if we think it's possible to get one into regular rhythm. And we have a very strong preference to try to get one into regular rhythm, whether it's using drugs or ablation or whatever. So that's the first point. The second point is, okay, so if we want to get into regular rhythm, how do we do it? Oftentimes we'll start with medications, but very frequently we end up with catheter ablation because ablation is more effective. But one of the new things that we found out is actually that there are better ways of doing ablation than what we had done in the past. And that's where I want to talk about the second point, which is pulsed field ablation. So to explain that, let's talk about what our standard ablation approach is, which is thermal ablation. And thermal ablation could be using heat, such as radio frequency, or cold, such as cryoablation. And these cartoons just sort of show different ways that we can do the ablation procedure. Now, the thing about thermal energy or standard ablation is as the energy propagates from the ablative catheters, it basically ablates any tissue that it gets in contact with. Now, of course, we want to ablate the heart tissue, but we don't want to ablate other structures like the esophagus or some of the important nerves. And also, if we ablate too much, we can cause narrowing of this vessel. And these are all problems. So when we're doing standard ablation, we're always balancing safety and effectiveness. So we can get a more effective procedure, but then we may start having complications. So we have to be careful. Now, what's new is pulse field ablation. Pulse field ablation is a different type of ablation that doesn't use heat. It uses high energy pulses for very short durations, for literally microsecond durations. And what's important is that it has some degree of selectivity of ablating the heart tissue without affecting other structures. So it has the advantage that, number one, it's very fast. The procedure times are cut down by 60, 70%. Number two, because of the tissue selectivity, there's less chance of damage to adjacent structures. And number three, because we're not concerned about safety as much, we can deliver extra lesions and improve our effectiveness without, again, spending too much time or being concerned about complications. So this is a pulse field ablation is now in clinical trials in the United States, and Sinai is actually the leading center for several of these trials. And I don't think I can overemphasize how transformative it is this will be for our field when this becomes completely FDA approved. And certainly now we're able to offer this to our patients in the setting of a clinical trial. And then the last point really quickly is people with atrial fibrillation, the other issue is stroke. And this shows an ultrasound image of the heart. And this little structure here is actually a clot that's inside the heart that's developed because the heart is not contracting normally. It's in fibrillation. Now, when this happens in most patients, we put patients on blood thinning medications to prevent this clot from forming. But some patients can't take blood thinners because of risk of bleeding, et cetera. And for this, we have other options, such as the Watchman device that many of you have probably heard of. This is a device, it's a catheter procedure. We go through the vein into the heart, and then we deliver the device. It looks like a little plug to block off this region so that any clots in here, such as shown here, can't travel in the bloodstream and go to the brain and cause a stroke. What's really new is that in addition to this first generation Watchman device, over the past year and a half, we now have two additional devices, Watchman Flex and another type of device called the Amulet, which are advances. These are second generation devices that are advanced and are even safer to implant. And they're easy and safe enough to implant that now these procedures don't even require anesthesia. We typically just do them with sedation. and the procedure takes only about 20 to 30 minutes. So this has been a big advance for those patients who can't take blood thinners to prevent stroke. So with that, I think I'll go ahead and stop, and hopefully we'll have time for some questions.
Thank you, Dr. Reddy. Appreciate that. Dr. Anulala is the Director of Heart Failure Research and the Program Director for our Advanced Heart Failure and Transplant Fellowship. Dr. Lala.
Good afternoon. It's such an honor to be here and to share this afternoon with you and to represent Sinai and hopefully share a little bit about what's going on in our section of heart failure. You know, it's so nice to follow Dr. Reddy and Dr. Swirsky, because in heart failure in our section, we obviously deal with the sickest of the sick. Patients young and old by conventional means, but with failing hearts who are considered to be at the end of the spectrum, who also may be considered for advanced therapies. And so that may include a mechanical pump to take over the heart when it's no longer able to pump out oxygen and nutrients to the rest of the body. And in certain cases, heart transplantation or heart replacement therapy in those patients for whom it's appropriate. So I might just share a slide or two as to how I kind of think about heart failure now with you. So let's see if I can do this without making it too futzy. Here we go. So I think of it's critically important for us to think of heart function, as you heard from Dr. Swirsky as well, along a continuum. We have these arbitrary ways of defining cut points as to what types of heart failure one might have. They include ejection fraction as being the most common way that we define whether someone has one specific type of heart failure versus the other, meaning that if you have a low ejection fraction, you're considered to have a low pump function for which certain therapies may be applicable. But you can also have heart failure in the presence of a preserved or intact pump function or ejection fraction. And what we're learning is that we really need to be considering heart health and heart function across a continuum. And it's really very gratifying to see this field evolve to recognize that fact. The main symptom of heart failure is really shortness of breath and inability to do the things that we would like to do. Or another way of looking at it is the energy required to do normal functions of day-to-day life is much more than would be expected given an age or sex of an individual. And so I think as we are evolving in our understanding of this space, concepts like you just heard about in terms of biologic age and chronologic age are incredibly important, because you could have a patient who is 30 years old, for example, who has a failing heart or is in frank heart failure, whereby his biologic age is actually that of perhaps a healthy 80-year-old. So again, I think for us to get out of conventional means of categorizing patients is really important. I think this concept, again, as you heard of biologic versus chronologic age is important. And for us to get past conventional means of categorizing patients is also very important. See if I can move across. I also think that the language we use really matters. Unfortunately, I work and I'm a heart failure specialist, right? So I work in the field of heart failure and then heart replacement therapy, whether that's by means of replacing it by a machine, as I spoke about, or an LVAD or a pump, or by heart transplantation. But I think we would all agree that the word failure is perhaps one of the most negative words that we have in our dictionary. And so it also gets to the point that I was mentioning earlier, where it really is only identifying those patients who are at the end of the spectrum. So when you tell patients, or when I tell patients you have heart failure, there's nothing more devastating to hear, no matter what age you are in. because we think of our hearts as central to the function of our bodies, which it is. And if it's failing, how can I go about my day-to-day life? What does that mean for my longevity? What does that mean for my quality of life? And how am I even interacting with you and talking to you if my heart is indeed failing? And so what I and many others in our field are really pushing towards is a change in our verbiage or our vernacular to focus on the word function as opposed to failure. And that's been a real sort of agenda change for us in this field. Our colleagues in Canada actually are ahead of the game in this respect, because they actually refer to heart failure as heart function clinics. And so we're hoping to see much of that cultural shift in the United States as well. When we do that, we can then think of health or heart health as opposed to just disease along a continuum, as I already mentioned. I'd also just like to mention that this concept of heart failure, if you will, puts us at a really interesting spiritual intersection, whereby we need to best understand what it is that matters to an individual patient. Sure, we've got incredible technological advances that allow for us to replace the heart by a variety of means. But is that right for every single patient? And that gets back to something that I consider as a vital part of my practice, which is understanding a patient's why. What is it that brings them joy? What is it that constitutes a good day? And based on that, based on getting to know our patients and establishing that personal human connection, we can then explain and offer the therapies that might enable them to continue to live a life that is filled with joy. And oftentimes that's not just about replacing the heart. That could mean an approach that's more palliative or more symptom driven. But I think more than anything, what I value and I'm always humbled by in this field is how important it is to get to know our patients as individuals, as opposed to just sort of patients from a distance, whereby we need to offer medical therapy or device-based therapy or even surgical therapy, but really understanding what their motivation is for life, who their support system is, who their ecosystem consists of. And then we can guide our patients and their families and their support systems accordingly as to what interventions or therapeutic approaches might be best for them. So hopefully we'll get to talk about a few more of these topics and others, but really excited to be with you here today and hopefully share some more things as they emerge in the field of heart failure.
Thank you, Dr. Lala. We have a number of questions that have come in even before you gave your talks, as well as the Q&A. So I'm going to start with some. I'll direct them when it seems reasonable, but anybody should feel totally free to jump in, okay? So Dr. Lala, we hear a lot about ejection fraction or pump function when we hear the words heart failure. Can you explain what this means? I understand how the heart can fail when the muscle doesn't pump well, but I don't understand how you can have heart failure and still have preserved function.
Yeah, thank you so much, Dr. Leipzig. You and all of us both. It is indeed a very complicated scenario whereby you can have, as you mentioned, intact pump function in that you're able to eject blood out of the heart. But what's critically important in order for the heart to be able to carry out its function is also its ability to relax and receive oxygen and nutrient-rich blood, whereby it can then pump it out. So if the heart is stiff, which can happen for a variety of reasons, high blood pressure, diabetes, coronary artery disease, aging as a natural process, all of these different factors intersect, among others, to lead to a certain stiffness of the heart muscle. And when there is stiffness of the heart muscle, it's not able to relax and receive that oxygen nutrient blood the way it normally would. So even though the pump function is intact, the relaxation phase of the cardiac cycle, which is just as important, is disrupted. And as a result, we still have the same symptoms, which is essentially, in a very oversimplistic way of thinking about it is backup of fluid into the lungs, which essentially results in being short of breath. So regardless of whether you have impaired pump function or impaired relaxation of the heart, one can end up with shortness of breath, which is sort of the hallmark symptom of heart failure.
Thank you very much. Dr. Swirsky, when you talked about lifestyle factors, you mentioned stress with kind of a strange intonation. Is stress good or bad? Are there benefits to it? And is there a difference between acute stress and chronic stress on the heart?
Absolutely. That's a very important question. Stress has been with us for a very long time. We have evolved with stress. And in fact, stress can save our lives. You know, stress, acute stress causes a phenomenon called fight or flight or freeze in animals. And so it essentially readies our organism, our bodies, to respond in one way or another to an incoming threat. Stress is processed, interpreted, and communicated in the brain, and it readies various systems to respond to a potential threat. That threat may be a predator that is trying to eat us, for example. So we need stress in our lives. The question is, how much stress do we need? And there is this concept of eustress versus distress, the good stress versus the bad stress. And this is where we really get into the idea of the incessant drumbeat of stress, sometimes low-level stress, without the relaxing from stress, that can be damaging. You know, when the body is always in a state of readiness, always in a state of attention, without having the opportunity to de-stress, so to speak, that can lead to all sorts of physiological adaptations that may be harmful to us. And so this is where chronic stress, of course, becomes particularly damaging, and there's much chronic stress in our lives. And we are really learning that it is exactly some of those phenomena that ready us, that can save our lives, that when they continue and become chronic, can actually elicit considerable damage, can increase inflammation, oxidative stress, high blood pressure, and so on, which can, of course, lead to the detriment of our health and put us at higher risk for cardiovascular disease.
Okay, thank you. Dr. Reddy, I watch a lot of TV, and so I see a lot about Watchmen, okay? And it's probably not good for my heart. But I also see these things about cardia and these devices I can keep with me to monitor my heart rhythm. Can you comment on whether there's any usefulness for them? Should I get one?
Maybe. Certainly there are a plethora of new devices, of wearable devices. I think everyone is aware, with even, for example, the Fitbit or the Apple Watch, that it can determine one's heart rate to a certain extent. I say to a certain extent because, for example, the Apple Watch, if you wear it, it looks at the pulsation, and that can give at least some idea of what the heart rate is. And sometimes it gives a reasonable idea of what the rhythm is. The way to really get a better understanding is to close the circuit by putting your finger on it. And by closing the circuit, you can actually get a single lead EKG. And that can actually be quite helpful sometimes in terms of identifying a heart rhythm problem. So if one has palpitations or even feeling of let's say, lightheadedness, getting a single lead EKG like this can actually be very helpful. You can go to the next level, such as the Cardia device, as you mentioned, Dr. Leipzig, which is a device that you can hold, which links to a smartphone, and that can record a longer EKG. It's a little bit higher fidelity recording, and that can be used. And that also, you can actually email that directly to your physician, and that can again be helpful. So sometimes we use these recordings because there's these systems because they're so readily available. For example, if we're again either trying to diagnose a rhythm, or let's say we treat the rhythm with drugs or ablation or whatever, and then we want to follow to see whether or not any residual symptoms are of concern. And of course, sometimes we go past all this and use more complex monitors that one can wear and give you a much higher fidelity understanding of what's going on.
Great, thank you. We have a couple of questions, not surprisingly, about COVID in the heart. So these are questions about whether COVID has been associated with arrhythmias or heart failure, and if so, is this only in people who had heart disease before? That's one. Two, is there a difference in the acute cardiac effects of COVID and the long-lasting COVID symptoms? And three, is there a relationship between the vaccine or the booster and getting cardiac problems? So open for everybody.
Well, maybe I'll comment on the rhythm issues, and maybe Anu and others can comment on the heart function issue. So the answer is yes. There's infections, and this is true for almost any infection, whether it's a COVID infection or influenza or whatever. The inflammatory reaction that occurs from these infections can certainly be a trigger for arrhythmias. Now, it's uncommon for them to be the cause in the sense that one would not have ever had an arrhythmia without it. They typically trigger. So in people who have the propensity, for example, of having atrial fibrillation, getting an infection such as COVID, which tends to be a very intense infection, can certainly cause atrial fibrillation during that time period or the period soon thereafter. There are also instances of first development of atrial fibrillation that we've seen. We've studied this and published on this, that we've seen atrial fibrillation form or manifest for the first time in the context of COVID. It can also happen, by the way, in the context of influenza infection. And it's almost like what we're realizing is this is almost like an arrhythmic stress test, that by having this intense inflammatory situation, then you could manifest these rhythm disturbances. Usually they'll get better, but there may be long-term issues that we have to deal with, just like any other atrial fibrillation. And then the one quick comment in terms of the vaccine, yes, again, the vaccine induces a very strong inflammatory response, obviously not lasting as long as the infection, but it certainly can induce it. And we certainly do see a transient increase in arrhythmias. It happens particularly in people who have a history of AFib. After getting the vaccine or a booster, you can see a burst, but then that quiets down very soon thereafter. So the answer is yes, it can, but I do want to also just sort of emphasize that these are self-limited things, and it should not be a reason not to get the vaccine or the booster if you otherwise, should be getting it.
Great, thank you. Dr. Lala?
Yeah, I think we're really fortunate at Sinai to have been, I don't want to use the word aggressive, but really proactive in trying to understand and unravel the connection between COVID-19 and the heart. I have focused a good deal of my research over the past 18 months on its effect, particularly on heart function. You heard from Dr. Reddy, and has done really seminal work in terms of its effects on arrhythmic burden. A couple of things. So one is, if you have a history of heart failure, regardless of your pump function or your ejection fraction, and you are hospitalized with COVID-19, unfortunately, your chances of having a poor outcome is twice that of the general population. So what we do know is, if you do have a pre-existing history or diagnosis of heart failure, regardless of your pump function, that you are much more high risk for having a poor outcome, meaning being in the ICU, God forbid, actually dying from the illness in the acute setting. So what does that mean? Well, do you just say they're depressed because you have heart failure? Well, No, but I do think that it has implications for how we follow these patients, of course, during the peaks of the pandemic, to ensure that there is adequate preventive measures in place. So we can talk about the vaccine in just a second, but certainly we have been very, very proactive about ensuring and educating our patients with a history of heart failure on the importance of the vaccine, because we know the alternative. There's a lot of fear. What if I get the vaccine? I already have heart failure. Is the vaccine going to make me sicker or damage my heart further? Well, yes. Are there isolated, very rare reports of that happening? Yes. However, the data showing that your outcomes, if you have a history of heart failure, are far worse if you get COVID-19 are incredibly compelling. So what I would say in this scary time for all of us, in these times of uncertainty, we use the data gathered to inform our decision-making. And I would say that the preponderance of evidence shows that if you get COVID-19 and you have a history of heart failure, your outcomes are poor compared to the general population. There are very, very rare cases of what we call myocarditis or inflammation in the heart as a result of having the COVID-19 vaccine. But quite frankly, we've never scrutinized the implications of vaccines on the heart to the degree that we have with COVID-19. So if we truly, truly did this for other vaccines, it is possible that we would see similar occurrences. Getting to the last point is, does COVID-19 in and of itself cause heart failure? So we did this study and we published on this as well, looking at our data from Sinai. Of over 6,500 patients, only 37 developed acute heart failure in the setting of COVID-19. That calculates out to 0.6%. So is it possible? Yes. Do we understand exactly why? Not yet. But is it common? No. So those are sort of my central take homes in terms of how we understand the intersection of COVID-19 and heart function.
Okay, thank you very much. We have a question about inflammation and inflammatory diseases. That topic just came up in talking about COVID as well. What's the connection between inflammation and heart disease, and does that extend to things like psoriatic arthritis, rheumatoid arthritis, things of that nature?
Yes, so maybe I can take this this question, and it's a beautiful segue to what we just talked about, to what Dr. Reddy and Lala discussed, because you've heard the word inflammation a few times in the answers to that last question, and certainly the immune system and the associated inflammation that it can elicit is in many ways a common denominator. I think it illustrates what I already mentioned in my introductory talk. So the immune system is everywhere, and it completely permeates our bodies, and the components of the immune system inhabit every tissue, but they can also move from place to place. So it's constantly patrolling our tissues, and it's always found in the blood. There are immune cells in the heart, we are learning, that are important to heart rhythm. And so there's some ongoing work that is now learning about how specific immune cells are actually interacting with cardiomyocytes and how they can contribute to arrhythmias. So what we're actually learning is that immune cells are not just there to defend us against infection or injury, but they are also participating in some of the normal functions of a particular organ. So we know that immune system is living in the brain, for example, sculpt our neurons and actually help us with brain development. We know that immune systems in the liver immune cells in the liver are very important to iron recycling, and so on and so on and so forth. So this is really an amazing system that learns, and that is found absolutely everywhere throughout our body. So with that in mind, it almost doesn't, it doesn't seem to be such a, you start to understand why under some very rare conditions, something like infection may lead to or may be associated with some of these issues that we see related to heart inflammation. Because what you have with SARS-CoV-2 is you have elicitation of a very rapid immune inflammatory response, and that is there to get rid of the virus. And sometimes what you really have is that response overflows and can cause collateral damage. This is why it's important to get vaccinated, because when you're getting vaccinated, you're educating the immune system in these areas of the body called lymph nodes, which is where immune cells congregate and talk to each other, that something like a virus may come and may cause damage, but you're not introducing a virus that is going to keep replicating and is going to push that cycle. So, and wherever we look at cardiovascular disease, I also briefly mentioned atherosclerosis, which in many ways is a chronic lipid-driven inflammatory disease of the vessel wall that can be the cause of heart attacks or strokes. That disease has a major immune inflammatory component. And we really know that immune cells are essential to that process. And so therefore, understanding those cells, I think, is going to be important in our understanding cardiovascular disease.
Fantastic, thank you. There's a question that is near and dear to my heart as a geriatrician. Is there an age cutoff for insertion of the Watchman device?
Yeah, so before I answer that, I do want to point out, because I want it to be really clear, that we have studies with tens of thousands of patients using blood thinners, and they work extremely well. So that's still our first line approach for the majority of our patients who have atrial fibrillation to prevent stroke. Having said that, certainly, and particularly in our older patients, it can be difficult to take these blood thinners either because of risk of falling or polypharmacy or a number of other issues. And the answer is not really. I mean, the procedure has been simple enough, and it's interesting. There's a national registry of patients undergoing implantation. The average age of the patients undergoing implantation is 76. And in fact, there are literally tens of thousands of patients who are in their 80s. I mean, I think our oldest patient was actually 100 years old that we implanted the device. I'm not saying every 100-year-old should have the device, but what I am saying is age by itself is not a cutoff.
Fantastic. How can we restore the ejection fraction? Can we restore the ejection fraction?
You know, I think it's so interesting, because if you told me that I had a pump function of 30%, normal being somewhere over 55, between 55 and 70%, and you said, okay, Dr. Lala, you have to choose between having a pump function of 30% versus 60%, but you still had heart failure. You know, I think as human beings, we're so numerically sort of driven, right? You want that A, you want that 90%, you want the highest number possible. What's been so remarkable in this field is that we've recognized that your ability to do things like walk a mile or walk 10 blocks or shower without shortness of breath or go up 2 or 3 flights of stairs is completely independent of your pump function. Not only that, but your outcomes, meaning how you do in the long run, your quality of life, the longevity of life, again, your functional capacity is also completely independent of the ejection fraction. So what does that mean? Well, I have patients who have an ejection fraction of 10% who can run 5 miles. I also have a patient with an ejection fraction of 60% who can't walk 1 block. So even though that's incredibly difficult for us to understand, and believe me, even as physicians who do this every day, it kind of blows our mind once in a while. the focus that I like to relay to our patients is that don't fixate on that number of the ejection fraction, but rather take a step back. And again, this is why I love the word function so much more than ejection fraction or failure, because you want to focus on your function as a human being. How are you doing in your day-to-day life? What are you able to do with ease versus dis-ease? And that's really the key point there. So I would say, as much as, and that's the most common question we get in clinical practices, doc, what can I do to bring up my function? What can I do to increase my ejection fraction? And I spend a lot of the time saying, yes, there are medical therapies that work if you have reduced pump function, and they are unbelievable and they are life-saving. And so we do our utmost to ensure that you are on at least, there are 4 different classes of medicines now that have shown that they can not only improve your pump function, but also your quality of life and your survival in general. But it's also important to take a step back and recognize that it's about the function as a human being, as opposed to that one number.
Okay, thank you. So that moves me over to Dr. Swirsky again, because are the ways that these different body systems interact with the circulatory system part of the answer to why the ejection fraction is just a number?
The answer is yes.
So I need to probe. Why?
No, the answer is yes, because like in sort of, there's different ways that we can think of the body, different metaphors that we can use for the body and these systems. We can say that the metabolic system, provides the energy. So that's sort of the input of energy that can be allocated in different parts, as we go about our lives. For example, we know that when we sleep, there are some processes get more of that energy need to restore our immune system and so on and so forth. So that is sort of the role of the metabolic system, right? I talked already about the role of the immune system as a system that patrols, if you will, our tissues, anticipates inflammation. This is in many ways guided by our nervous system, where, for example, among the many things that happen in the brain, and the brain is a very complicated and amazing organ, this is where the circadian clock lives. So this is where our physiology is maintained throughout and the course of a 24-hour day, where the circadian clock interprets light through our eyes, interprets food that comes in when we eat, and synchronizes many of the physiological processes. And of course, then you sort of bring in other parts of the brain that are relevant to how we feel, to the wellness, to how resilient. So Dr. Lala already talked about resilience and how we can build resilience. And so really integrating and these systems, understanding how they talk to each other, really in this very sort of broad context of the environments that we inhabit, is, I believe, the answer, and certainly from the answer, the approach and the way that we should be thinking about our cardiovascular health.
Thank you. Our final question is actually from 3 different questions, and it goes to you, Dr. Reddy, about pulsed field cardiac ablation. So the first question is, I guess they're kind of the same, 2 of them. It's not yet ready for prime time. So if somebody's suggesting that I have an ablation, should I wait until it is FDA approved and I'm able to use it? And then the second question is, if I had a thermal ablation the first time and I end up needing another ablation, do I need to have another thermal, or can I switch kind of Moderna or Pfizer,
I'll skip the Moderna Pfizer question. That's a much harder question. This is one of those questions that depends on the situation. For example, look, I strongly believe that pulse field ablation is going to be the future. I mean, in 4 or 5 years, when everything gets approved, we won't be having this discussion about what energy source. It's going to be pulse field. But in this time in between, I would say, number one, if 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 a patient qualifies for one of the clinical studies with pulse field, then that's something to consider. Doesn't mean you should necessarily do it. You should talk to the doctor, understand what's the data behind that, and perhaps that's something to consider. And then it also depends. I mean, let's say you don't qualify, then should you wait? Well, it depends on how far your AFib has progressed. For example, let's say you have intermittent AFib. It's reasonably well controlled with medications, but you'd rather not be on the medications. But you could be on the medications. So that's an example where probably it makes sense to wait, and depending on how long it is. And if at some point the AFib progresses, then go and change to a regular approach. On the other hand, let's say you have a more continuous atrial fibrillation. In that situation, the marginal benefit of waiting for pulse field will probably end up being outweighed by the downside of staying in atrial fibrillation for a long period of time, because that causes other inherent atrial dysfunction. So the advantage of waiting is negated. So I think it really depends on the patient situation, and it's something to discuss with the physician. And then just last really quickly, no, you can mix Moderna and Pfizer at least for AF ablation. If one has an ablation with one energy source, there's no reason why you couldn't use the other. That's from a medical perspective. From a very practical perspective, many of the clinical trials don't allow patients who've had previous ablation, but there are one or two that do allow it. So again, that's just a practical regulatory issue.
Thank you. So I really want to thank our panelists. I think we've had a very exciting discussion today. And so thank you to Drs. Swirsky, Reddy, and Lala. And I want to remind you all that heart health is brain health. So everything you hear here, okay, are things that will, whether it's lifestyle or function, dealing with your AFib, doing all of that will help your brain function as well. So take heart, so to speak, from that. And before you log off, I have one final important point to leave you with, and that's that all of the innovative ways we just discussed were all made possible because of extraordinary philanthropy. But the work really has only just begun, and we need your help to keep innovating and bring these innovations to a world in need. There's a special QR code or flow code that will be on the screen. Just point your smartphone camera at it, and it will take you to a web page where you can support this urgent work. Thank you so much for being with us today, and stay safe.